cranial nerves 12, we can divide into upper cranial nerve and lower cranial nerve. If somebody has to do a upper cranial nerve examination, you have to do 1 to 6. If somebody has to do a examine this patient lower cranial nerve, you have to perform the cranial nerve examination from 7 to 12. And then we can ask about the motor cranial nerve. What are the motor cranial nerve? So before the examination, first you have to introduce yourself. Golden rule of examination in medicine. So first cranial nerve is an olfactory nerve. Olfactory nerve usually we don't examine in a clinical setup, in an exam setup. But how can we examine the olfactory nerve in real life? Yes, you can. What you have to do is, first you have to ask the patient whether you have any problem with the smell or taste. Charles, do you have any problem with the smell and taste? No. He says no. Right? Then what the next step? And you have to take two different smell of you can take one syringe or the small bottle, right? Small bottle, and then ask the patient to close eyes and keep into the nostril, one nostril, and ask the smell. So if it is a familiar smell, so coffee smell or the lemon smell, patient will say that. You can say that correctly. And then test first nostril first, and then the other different smell, and close the other nostril and ask the patient to close and ask what do you feel? He will say that okay, I can feel a lemon smell. So that you have said it correct. And what is second cranial nerve? Optic nerve. So optic nerve examination, optic visual the second cranial nerve. There are 5 components: visual acuity, right? Visual field, color vision, and then the visual reflexes, right? Like the accommodation reflexes and the Fundoscopy. To examine the visual acuity, you need a chart called Snellen's chart. Snellen's chart, right? In the exam, you have to have a pocket Snellen's chart. Should carry with your the overcoat during exam. The usual visual acuity chart, Snellen chart, will keep what's the distance between 6 meters. 6 meters, and the modified one, the pocket one, we keep over the 1 meter distance. 1 meter distance, and we will ask the patient to close one eye, right? Not to close like this, like to close like this, and ask to read, and then you recheck the other side. So from start with the top one, right? And then the big letters, and gradually coming right. You have to write the document. Right side 6 by 60 or 6 by 80. Normal visual acuity is 6 by 6, right? 6 by 6, the lowest, the bottom one, the small printed letter, and 6 by 9, 6 by 18, 36, and the 60. If somebody can't read even up to 6 by 60, then what you have to do? Finger count. Right? So you have to ask to can you close one eye? Right. So how many fingers? 5 now. 6. So even the patient can't count, you can't move. You can you have to wriggle, or you have to move your arm and then see whether your arm is moving. Then we come to visual field. Visual field is the bedside examination. We call the technique we call as confrontation technique. Confrontation technique, right? The proper way of the smell assessment is the object. The accurate way is a perimetry, which is done in the IDA. But the visual field assessment, we get a rough idea what is his visual field. Always we compare our visual field with the patient visual field, right? Visual field. So that is called confrontation method. So then the patient should be lie on the bed, right? And then the distance is an arm stretch distance, right? So you have to take the 1 meter You can't take a 1 meter rule and the tape and wait. I have to keep the 1 meter distance, right? So the arm stretch distance. And always, then what is the next thing? The patient's eyesight and the examiner's eyesight should be the same height. And then you have to give the correct instruction to the patient. What are the correct instructions? So first, you have to look at the tip of the nose. You have to say the patient, okay, don't move here and there, look at my tip of the nose. And the first you take the visual in attention and then ask to the move. You take the visual feel like this, right? So upper feel, lower feel, and then you have to move your both eyes and see whether the patient is can see wiggling of your fingers, right? And then what you have to do is ask the patient to close one eye, right? So close one eye, right? And then the same eye, the respective eye of the patient also should be close the same eye, and then move your finger, right, from lateral to the medial. And then move your finger in the middle of the field. So now we are in the arm stretch, one arm stretch, and middle of the finger is here. And then you move your finger from four corners, from here, that is for the temporal field, and from here, here. And ask the patient whenever he see the patient and ask to raise his hand or can say yes, right? And what the important thing is, the important instruction should not move is that right now. Say suppose that when I am bringing my patient the finger here, if this training is here, right? So then this visual field is, you can't compare. The most important, don't turn your head, right? Only concentrate to my tip of the nose. Whenever you see, please let me know that I can see. Right? So whenever you can see, you have to say yes. Yes. Now can you close your eye? So now I am closing. So you have to look at my tip of the nose, Charlie, right? With your open eye, but don't move your eye. Whenever you can see, first instance you can see my finger, say yes. Right? You can close this one. So now we check the temporal field. Now we are checking the nasal field. Yes. We will do the other side. Right? So you can close this thing. Right? So please look at my hand. Right? And whenever you see first thing, see yes. Yes. Third one is the color vision. For color vision, you have to provide a chart called which chart? Ishihara chart. Right? Ishihara chart. And the Ishihara chart will be given to the patient, and we are checking their different color vision. Usually, we are not expecting you to bring the Ishihara chart the examination. So, if you have Ishihara chart, that's all. Right? Then we check for the visual reflexes. What are visual reflexes? Two reflexes are there. Another two reflexes, accommodation reflex and light reflex. Light reflex we divide into two, direct and consensual. Direct and consensual. How are you going to check the visual reflexes? Right? So what you have to do is, so first you have to tell the patient, so I am going to flash a light to your eye. So I am going to flash. So you have to start from here, right? Here, and gradually you have to bring to the light to the center and see what is happening to his the pupil, right? So that same side pupil will be constricted, that direct, and at the same time, so you have to look here, so that is concentric, right? So you have to keep your hand over the nasal bridge. Right? So bring your torch from side and come to the middle and see what is happening to the pupil, and at the same time look here, that is this direct reflex is present and consensual reflex is also present, and do the other side, right? So then you have to compare, you have to look at the straight side, right? So here direct is pupil is constricted, and then at the same time sometimes the consensual reflex you can't see properly, but always you have to keep your hand like this and see the direct and consensual reflex. Then what is the next one? Accommodation reflex. You have to look at far away through your window to look at the anatomy department and see what is happening. What is happening to this pupil, right? And then you ask you, okay, look at this tip of the pen. Can you see that? Both eyeballs with convergence, right? Convergence, and then that is called accommodation. And when you look straight, sharp, far away, right? Okay. Now look at the tip of the finger, right? And so it is accommodation. This accommodation reflex is strong. This next one is ophthalmoscopy or fundoscopy, right? Fundoscopy examination. So this is ophthalmoscopy or fundoscopy, right? Fundoscope, and then so you have to right? So you have to so it need a correct batteries, right? And then so you have to on and see whether there is a light is coming. There are three areas, right? And the green one, the normal yellow one, or the green one, and here, right? And then depending on your the vision, so there is a there is a the green light button, so you have to rotate it, and so there is a 0 in your vision is normal, and you can put it to the 0, right? And so it should be a well vision, and the correct instruction should be given to the patient. So I am going to look at the fundus, right? The patient doesn't know what is fundus, you have to say that I am going to look at your eyes, or I am going to the nerves through your eyes. So what you have to do is holding the ophthalmoscope is one of the important things, right? And then the patient head should be fixed, right? Patient can't move here and there, right? And the patient should be here. And then what you have to do is first, if you are a glass wearer, using the glass, the patient is a glass wearing, and then you have to see the fundus through this glass, otherwise you can't see fundus properly because of the refractive, right? So what you have to do is, so the right eye, when you are examining the right eye, so you have to hold the fundoscope from your right hand, this is on, and then first look here, and from the 1 meter, 1 feet distance, look at here and look at the fundus. You can see the reddish in color, we call a red reflex, right? Red reflex, why red reflex is important? When there is a cataract, right? There is a thing called cataract, and then when there is a cataract formation, red reflex will be absent. First thing is absent is the cataract, it's a red reflex. Then you close your, slowly you have to take your ophthalmoscope, put into this hole, like this. So why you are not holding when you are looking the patient's right eye, you are looking through this thing, you will go and hit the patient, right? So you should not do that. So avoiding that one, so you have to go this one. And then it's a difficult thing, right? But you have to make practice, right? But don't worry about doing the second MBBS period, that we will not pass in the exam or that examination, right? So, but in the final year, you have to practice how to examine fundoscope properly, right? Okay, hold with the right hand when you are looking at the patient's and then you can see the light, and then first thing is you can identify what are the areas in the fundus. So you can see the optic disc and then the optic cusp, and then there are blood vessels, retinal artery and the retinal vein. So then, so first look at the, you can see the retinal arteries, and you identify, and along that you come to the middle of the fundus, and then you can see the normal fundus. And then you have to move to see the other quadrant, so upper quadrant, lower quadrant, and then finally ask the patient to look at the light. Whenever you look at the light, and the patient will, when he is then you are flashing the light to the macula, right? And they are flashing the light, and then that's the pupil will be tested, but that's the last. When you are examining the left eye, right? So hold the ophthalmoscope from the left eye, and then fix and ask the patient to always look at straight, right? From this side, you have to look at the straight, or you can get the other person's help, right? So then you show your finger, right? So keep your finger here, and ask him to look at the tip of the finger. Then he is not moving his eye. So that's one of the important things is a focus. And he's looking at this girl's finger tip from the side hand, while he's looking at the finger here. So that you have to practice. Now the third, fourth and sixth we examine together. Right? Third, fourth and sixth. Right, that's your Oculomotor, Trochlear and Abducens. We examine together, and there we are looking for what's the first thing is we have to, under inspection you have to see that whether the patient is having what? Ptosis. Right? What is a ptosis? It's a grouping of eyelids. Right? Depending whether it's a partial ptosis or complete ptosis, you have to see that. Right? So first thing is you have to look for the under inspection whether the patient is having ptosis. Right? Partial ptosis or the complete ptosis. And then the second thing is strabismus. Strabismus means deviation of eyeball, right? Strabismus or deviation of eyeball. Sometimes the eyeball will be deviated to the medial strabismus. Sometimes eyeball will be deviated to the lateral strabismus, right? Lateral strabismus, right? Then you have to see that, okay, what is the position of the eyeball? Second thing. Third thing is what? Size of the pupil, right? Size of the pupil. So it's again you have to flash. Then when you are flashing the first time, so you can see that. Okay. So again you have to see that. Okay, the pupils are both sides equal, right? Both sides equal, and so that is size of the pupil. That's under inspection. And then what you have to perform, ask the patient to look at my finger and move your eyes without turning your head. So you have to ask the patient to move the eyes only. Right? Move your eyes. So you have to look for what is the movement of eyeball. Can you see that? Okay. And look up. Right? Look down. Can you see double or single? Single. You have to ask. And when the eye movement, the finger is moving away, and if the patient is having double, you have to say that the patient is moving that I can see double. Right? And then at the same time, you have to see the movement of the rhythmic oscillatory movement of eyeball. That's called nystagmus. Right? So nystagmus has to be put. And then look here. So these eye movements are okay. And look up and down, right? And here, up and down. So tell me that what are the muscles you are going to take. So what is the muscle supply? How are you going to, what is the mnemonic? LR6 SO, right? LR6 means lateral rectus is supplied by the sixth nerve abducer, and superior oblique is supplied by the right. moving to this side. That means this lateral rectus is gone, right? And this medial rectus is intact. So moving here, and when this eyeball, this eyeball is moving to here. So lateral rectus is gone. So this the right abducen is gone. That is abducen. And the Trochlear superior oblique. Right, so superior oblique. So what is the thing? And you have to ask the patient to look at inferior and lateral. That is superior oblique, right? And then inferior oblique, right? And this is superior rectus and inferior rectus. So that is how you check all three nerves. But eye movements are important. Depending on the third, fourth, and sixth cranial nerve pulses, you can judge. Right? Say suppose patient is having a complete ptosis. One is completely closed, and then you open the eye, and then you can see the eyeball is deviated to lateral side. So that means his abducen is sixth nerve is intact, and then the pupil is dilated, mydriasis. Right? Mydriasis. Then what is the diagnosis? Complete. I will say complete. Complete ptosis, lateral strabismus, the deviation of eyeball to the left side, and mydriasis. So what's the diagnosis? Complete oculomotor nerve pulse. So third nerve pulse. Right? Third nerve pulse. And the last thing of the third, fourth, and sixth examination, so what you have to do is, so first look at the pupil size, and you have to move your flashing of light in an arc-well manner and see what is happening to this direct and consensual. You can do it under the visual, the second cranial nerve. What you are looking is when you are moving the flashlight from one eye to other eye, what is the normal response? When you are flashing a light, the pupil should be constricting. Right? Pupil should be constricting. When you are changing, right? And when the light is flashing, instead of constricting, it is dilated. We call as afferent pupillary defect. Afferent pupillary defect. Where do you get it? When there is a lesion in MLF. What is MLF? Medial longitudinal fasciculus. What is medial longitudinal fasciculus? It is the connection. And it is a neural bundle which connects third, fourth, and sixth. Right? This third, fourth, sixth nuclei are connected the longitudinal bundle of fasciculus we call as a MLF, medial longitudinal fasciculus. When there is a lesion, you will get the afferent pupillary defect. Afferent pupillary defect is that when you are flashing the light, when moving, the instead of constricting, it is dilated. Right? That is third, fourth, sixth. Now we are going to examine the fifth cranial nerve, that is a trigeminal nerve. It has a two components, motor component and the sensory component. Right? The motor component will start always motor first, sensory second. Trigeminal has three components. What are these three components? Ophthalmic, maxillary, and mandibular. If somebody asks surface marker sensory thing, this is how my professors during my second PhD professor teach us how to do the surface marking of the three areas. Either ophthalmic is when you close your eyes like this. This is a surface marking, and the mandibular is when you close, keep your arm like this. That's a mandibular division, and the rest of the thing is maxillary. Right? Do yourself. Right? So this is an ophthalmic, right? And this is maxillary, and the rest of the thing is mandibular. Right? So that is sensory component. So how are you going to do a sensory component for which you need a light touch button? If you can feel, you have to say yes, right? And it's asked, okay, same, and here, right, and here, and here. That light touch, the patient asks the patient, okay, if you feel it, tell me yes, or in Sinhala you can say Danenama, or O, right? And then what's the next thing? Pinprick sensation, right? You want to take this tool prick, and tool prick you have to keep here, right? And here, 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 and here, and here. Right, 6 points. Right, so comparing both sides. So third important thing is what? Corneal reflex. Right? Corneal reflex. How to do a corneal reflex? Again, you need a clear piece of cotton wool. Right? If you have used that cotton wool for 3 months ago and put in these things and you have piece this common cold and stretching things and sometimes rubbing your sweating, and if you put in your sensory pack and bring it the exam. So don't do that with this because you are touching the inside the eye. So it's a very thin, and you want to take the permission again. And dirty cotton wool should be avoided. Remember that, right? For the hygiene purpose. What you have to do is with the help of the right. So ask the patient, right? So then what you have to do is to take a cotton wool and make it a thread, right? Small thread like in a cotton wool, and ask the patient to look at here, this time, and keep on looking, right? Looking, and then what you have to bring that cotton wool from this side and touch the sclerocornea junction, right? Not the sclera. When we are to perform the corneal reflex, some student come and touch the sclera. Sclera is the whitish part, not the sclera. Right? Sclerocorneal junction is a blackish area and the white. That area you have to touch. Whenever you touch, he will close. He will blink this side. That is called direct corneal reflex. At the same time, he will blink the other side. That is a consensual. Right? Corneal reflex. What is the afferent pathway? Is trigeminal. Efferent pathway is Oculomotor. So orbicularis ocular, or the superior elevator temporal superior, should be closed, right? So this is direct and consensual. Do the other, then other side. So you have to come to this side. Okay, look at here, right? So bring your cotton wool from here, right? And the threaded one, the clean one, and touch the sclerocorneal junction, and he will blink, right? He will close whenever, as soon as it touch, right? And then he close his side, and then the other side is also. So we have said that his corneal reflex, direct and consensual, both are normal. Right? Now we come to the seventh cranial nerve. What is the seventh cranial nerve? It is the facial nerve. Right? The facial nerve also has a two component, motor component and the sensory component. Right? Motor and the sensory component. And then the motor component, what we are going to do is, and ask to him to first start from here to here, right? Ask, wrinkle your forehead, right? So you can see, right? And then the second thing is, and the close your eyes. Close your eyes, right? Not allowing me to open it. Please close your eyes and not allowing me to open it. Right? So likewise, so then he can close, right? Screw your eyes or close your eyes tightly, allowing me to not to open. Sinhala you can say that as Tarakala right? So you can say that, okay, so not allowing. So he is the orbicularis oculi and the levator temporal working very properly. And why it is important when there is a facial nerve also, when it is very mild one, if you ask to forcefully open, and it will be open. You can see, and the patient can't close properly, right? And then we go down and ask to blow your mouth. Right? Blow your mouth, and we will ask, right? Press this and see, right? Press this and see. So we can blow your mouth and show your teeth here, right? So your teeth. So you have to see the symmetry of the lips, right? See, symmetry of the lips, very important, right? So if it is a facial nerve palsy, if there is a damage, and then this the this muscle is weak, and then one side is right, one side is working and the other side is not working. Right? So if the patient is having the patient unable to close eyes and unable to the whistle or the when he is showing the teeth and unable to moving his lips, then the upper and lower half is both involved. Then we call as a lower motor nerve facial nerve palsy. Right, when the upper half of the face and the lower half of the face both affected, we call as a lower motor nerve facial nerve palsy. Where is the lesion? Lesion in the same side, right? Same side. It could be extending from the geniculate ganglion to the lower motor pathway, right? But when there is what is upper motor nerve facial nerve? Upper motor, the facial nerve nucleus has a two components. There's a famous neuroanatomy question, right? Upper motor, they ask that the upper motor nerve lesion, what is happening? They get a contralateral lower quadrant lesion. Right? If the patient is having contralateral, say suppose Charlocus, the blood clot and the stroke went and the facial nerve is damaged on the left side. The present patient is right side, right lower quadrant. Right? So he can close his eye properly. Even with a forceful thing, can't open. But when we ask to show your teeth and this side is not moving up. So that is low upper motor type facial nerve. Upper motor type facial nerve, you have to think about, okay, if the upper motor type facial nerve here, lesion is contralateral. Right? If the upper motor nerve lesion is here, the lesion is this side. So because of the upper motor nerve, the nucleus has the nucleus has upper and the lower part. The lower part has a double innervation from both sides. Upper part has only one side. That is why it is there, right? So say suppose that the patient got a stroke here, and the lower motor, the upper motor, the facial, and the same side the patient have a right upper limb and lower limb. And then you say that okay, this patient have a where is the lesion? Then the oculomotor, the nucleus is located in the brain stem. So that is simple. That is facial nerve palsy, right? But the under facial nerve, when you what is the sensory component of the facial nerve? Yes, very good. Anterior to the supplied by the coda tympani, right? Coda tympani. So usually we don't test we don't put things in the anterior to the exam. Eighth nerve is a vestibulocochlear nerve. Vestibulocochlear nerve. The good test is that the whispering method. Whispering method means that when you are checking that you have to close this side from here and you have to ask that okay, I am telling the number, please repeat the number and tell me. And then you have to reduce the strength of voice and gradually away and then ask the patient to repeat it, right? And that's a very good test, right? So when you are closing here, right, so you have to rub. Right, or you have to close this side, otherwise you won't get this one. Charles, can you repeat this number? 50. Right, so you do the same thing. Right, so close this eye here. Right, now but then you have to go on the release and develop space. Then we come to a ninth one. It's a glossopharyngeal nerve. Glossopharyngeal nerve, again, what we are looking is we have to perform two things, right? Three things actually. First thing is ask the patient to cough, right? Second thing is you have a glass of water, give it to the patient and ask to swallow it. Third thing is open the mouth and say ah and to see the movement of the uvula and the palate, right? Upper part of the palate, posterior part of the palate, right? So can you give me a good cough? So he can have his cough reflex is there, right? And then if you have a glass of water, you can give open your mouth, right? Now fully open and then say ah. Say that. Now you can see that. Say R. Say R. Right. The uvula is moving. Right. Uvula is in the middle and it's moving up with the soft palate. So that is his glossopharyngeal nerve is working. And 10th vagus nerve. We usually don't have things to check vagus nerve, right? So no, the cranial nerve is the vagus is supplied to the distal part of the organ, and then we are not usually checking the 10th nerve, and then the 11th, right? 11th, what is the 11th nerve? The accessory nerve. It is supplied to the two muscles. What are the two muscles? Sternocleidomastoid and trapezius. How are you going to check the sternocleidomastoid and the trapezius? First thing is asked to struggle the shoulders against your hand. Right. So that is first. And the second thing is sternocleidomastoid. Right. So this side and this side. So keep the head like this, and you have to ask that turn the head against your hand, and then while he is doing, and you have to palpate the sternocleidomastoid. Here is the sternocleidomastoid. Can you turn your head to the left side against my hand? Right, so this is nicely working. Right, so this is, and turn to this side. Right, so here is pretty obvious, and this is very contracting. Right, and the 12th is hypoglossal nerve. Two things you can do that. First thing is ask to open the mouth and put the tongue out. Right? Open your mouth and stick your tongue out. So it should be in the middle. Right? If there is a deviation to the one side, lesion in that side. Right? So tongue is deviated to the right side, means that there is he has a right-sided hypoglossal nerve. And then the second thing is ask to put the push the cheek inside the mouth with the tongue. So and you have to do that for the like this, right? So then you have to palpate it. Push your right cheek with the right. So he can push it in that his tongue is working properly, right? So the left side. So then you have to feel it here. His tongue is here, and we recall if there is a hypoglossal nerve, patient can't do that. So that end the cranial nerve examination. So at the end of examination, you have to thank the patient, thanks Shalu, and then you have to present your case.